There are a couple of other important considerations when we're caring for the patients with acute graft-versus-host disease. Turns out I'm attending on the ward right now. We have a number of these patients. And so I think it's important to not underestimate the other components of care that go into the patient with acute GVHD. So we have to do meticulous wound care for skin disease. There's the element of resting the intestinal tract and providing parenteral nutrition to feed the patients during their time course in the hospital with acute GVHD. And it's really a multidisciplinary approach involving our dietitians, our physical therapists, our nurse colleagues, our research coordinators, and our research technicians, and really couching expectations with the patient. So understanding that the patient is going to be in the hospital for several weeks should they be unfortunate to get acute graft-versus-host disease. Any comments on sort of the supportive care of the acute GVHD patient you want to make?
I just want to add to the multidisciplinary approach that it's critical to have our infectious disease colleagues involved, because even in the absence of GVHD, patients in the early stages after transplant are quite immunocompromised and are subject to all sorts of bizarre and unexpected infections, in addition to the usual expected infections. And in addition to that, many patients will get pneumonias and things of that nature, and so our pulmonary colleagues are often quite helpful in that regard as well. With respect to conventional supportive care, I think, for skin involvement, the dermatologists are often quite helpful in terms of not only coming up with topical regimens to ease the discomfort of the skin, but to help facilitate healing and to reduce inflammatory manifestations of the skin. And of course, for somebody with very severe GVHD, what we would consider stage 4 skin, blistering graft-versus-host disease, we sometimes have to have them in a burn unit because they can actually desquamate most of their body. Stage 4 skin GVHD is relatively uncommon, but severe intestinal graft-versus-host disease is quite common, and this is where we need to confirm these diagnoses by biopsy, because there are a number of things that can mimic graft-versus-host disease. Adenovirus, cytomegalovirus may not be apparent in the blood. They may not seem like a conventional viral infection, but we can get intestinal involvement with these. And of course, if you're treating an adenovirus infection with prednisone or CMV with prednisone without specifically targeting the virus, you may make things worse. So these are, I think, extremely important corollaries to just in addition to the conventional immunosuppression that we use, that we just need to be aware of.
And I think you touched on a very important point about involving our colleagues from infectious disease. We certainly have made some strides in the management of acute GVHD, but over time, probably the biggest contributor to our success in the last 10 to 20 years has really been the advent of broad-spectrum effective antifungal agents and the use of drugs that have CMV activity, both in the preventative and the therapeutic sense. We have, in fact, improved outcomes of graft-versus-host disease. There are analyses from the CIBMTR, for example, that have documented that the outcomes of late-stage GVHD are improving, but I think we do have to ascribe some of our successes to our colleagues, particularly in infectious disease.
Absolutely. I think, as I think back over my career, in the early days, it was amphotericin, which was a horror to administer. 25% of our patients died of CMV. At the moment, in our program, we do about 275 allogeneic transplants a year. Maybe 1 or 2 die of CMV. Whereas in the previous era, we would have expected close to 75 to 100 of them to die of CMV. So that's how critically important advent in infection control have benefited our patients.
What else? What's the next step in acute graft-versus-host disease? Where is our field moving, do you think, in the next few years?
I think most of us would agree that prophylaxis is more important than therapy. If we can maintain graft versus leukemia, if we can foster immunological reconstitution and prevent graft versus host disease, this is the holy grail of transplantation. Prevent GVHD, allow effective reconstitution, and provide an effective anti-cancer effect, then we win, and our patients win. So one of the newer regimens that is becoming increasingly popular is the use of post-transplantation cyclophosphamide. This is, it's maybe 6 or 7 years old. Was a little bit counterintuitive, took a little while to catch on, but actually has been very effective at controlling both acute and chronic graft-versus-host disease. We still don't know to what extent the rest of the Holy Grail can be achieved. That is, these patients are extremely immunocompromised, and there may be some degree of loss of graft versus leukemia. What our group is focusing on are things like cancer vaccines. So one of our colleagues, Vincent Ho, will generate a leukemia vaccine from the patient's endogenous leukemia. We're using that to foster the graft versus leukemia effect in the absence of graft versus host disease. We also have some cellular therapies going on. You might want to comment on natural killer cells, for instance.
So we're working a great deal. Our colleague, Dr. Rizwan Romi, is working and leading our efforts in providing cellular therapy against tumor relapse by generating interesting NK-derived cellular products. But what you're trying to say is that simply solving acute graft versus host disease isn't the big picture answer. It's taking care of the primary malignancy and sort of putting GVHD in the place of preventing complications, preventing the disease from initially relapsing, and sort of fostering long-term immunologic reconstitution and overall good health.
I agree.
Well, Dr. Anton, thanks very much for joining me here today at this Enclave Insight session on acute GVHD. We went over some of our institutional practices. Notably, I learned most of these from you. But it's been a pleasure talking to you today, and we hope all of you learn a little bit about this.